Good evening, everyone. Welcome to Gut Over It. My name is Dr. Vivian Asamoah. I'm a gastroenterologist and functional medicine provider in Katy, Texas. Thank you all for joining me on this Sunday night. This is our last night of Gut Over It. I did it, guys. I did the challenge. I did it. And you know who you are, who dared and challenged me to do a full month of a live video on Facebook every day at 9 p.m. to get over my fear of social media. I'm over it. I'm so over my fear. I can do a video anytime, in the shower, going to work, I've been scoping, bring it on. I'll do the video. So I did it, guys. And she knows who she is. She knows who put me up to this challenge, but I'm so glad I did it. I'm so proud. And tonight is our last night. And I thank you guys all for joining me every night through rain, snow, storm, sleet, power out, everything. And tonight we wanted to go strong with a topic that we feel is really evolving in gastroenterology and in medicine in general. And I thought the best person to discuss this topic with me was someone who was kind of going through the trenches with me every single day, someone who I admire. And when they say always, big up and give respect to people within before you give respect to people outside, right? As my mom always says, charity begins at home. Prop up those who are close to you before you prop up those who are outside and, estranged from you. So tonight, I'm going to start by, I was going to do a whole bibliography of, her resume and all that stuff. And then I said, you know what? I think the best thing to do is actually to talk about something tell it from the words of a patient who had something to say about this person. And I think it wraps it all very nicely, even way more than I could say. And this is what they said about her. Donna Lee was very pleasant, helpful, and knowledgeable of any questions we had regarding my health conditions and my family concerns. More importantly, she was very patient with me. She is an excellent asset to your office, Dr. Asamoah, and definitely has a servant's heart. We truly need more of her in our world. I want to introduce you guys to my physician assistant, partner in crime, the most compassionate, patient person I know. Really a force to be reckoned with, because she looks like quiet and everything, but she is not. But I really admire her. She's brought a tremendous amount to our practice in terms of knowledge and in just terms of compassion, kindness, and patience and servitude towards our patients as well. So she came all the way up to my house to do this last Gut Over It with me.
Series finale, guys.
This is the finale. It's Donna and Dr. V going all the way and talking about SIBO. So we kind of want to talk about our personal experience. But before that, y'all give a shout out to Donna, put in a like, share some love, put in some comments, ask her about David, ask her about her dog, Honey. I keep calling him Happy, but he's Honey. All right. But we want to talk about SIBO and kind of like the impact SIBO has had on both of us as gastroenterology providers. And we want this to be as interactive as possible. So we are looking for questions and comments, and we are ready to answer. So Donna, cheers. To the last Gut Over It. I'm going to have you dancing to some African music, right?
I don't know that. Oh, maybe I can work on my hip movements.
All right. All right.
All right. So I'm going to just start off with some basic questions, just in case there's some patients that, or anybody who hasn't known about SIBO. Mm-hmm. So how would you explain it to a patient?
So SIBO, I think, is more like dysbiosis. It's an imbalance in the gut microbiota. We know now from the Human Microbiome Project that we coexist with bacteria, parasites, fungi in our entire body, right. From skin, but most importantly, where a lot of the bacterial ecosystem is in the gut. And we know that it exists in different amounts in different parts of the gut, different species, different quantities as well.
Yeah.
And so when the speciation is off, when the quantities are off, then there's what we call dysbiosis, right? And then when the dysbiosis gets worse, then we call it the small intestinal bacterial overgrowth, SIBO.
Right.
Yeah.
Okay. So I didn't even know about SIBO until I actually started working with Dr. Samwa. It was actually new to me, so I felt like this was something that they never really taught us in school. So is this actually more common?
That's a good question. I don't know, Donna. I think that we are actually diagnosing it more because we're paying a lot more attention to it.
Yeah.
I think SIBO's always been there, but when I was in school, I learned that SIBO was more obvious in people who had, like you would test for people who had diabetes, right? Like who had
Motility, yeah.
motility issues, right? Who had surgery, so scar tissue and adhesions. And even in terms of Crohn's and patients, it wasn't really discussed that much. But I think SIBO was always there, but we were underdiagnosing it
Yeah.
because we weren't always looking for it in the right populations.
Right. So there's actually this, I've learned that there's a big connection between IBS and SIBO. So
Yeah.
how does that coincide with one another?
Yeah, that's I think one of the biggest things that we've learned in gastroenterology. Dr. Pimentel, you
Yeah.
listen to a lot of
Yeah.
his podcasts and his shows. He's the one who's been doing a lot of research in SIBO and IBS. And basically what he's been able to show is that there is a root cause to IBS, right? And this is why we talk so much about functional
Yeah.
medicine and going back to root cause. Like before we used to think IBS, which is irritable bowel syndrome, guys, was like noted in, women who were kind of anxious and
Yeah,
stressed out and
yeah.
more like a psychological issue,
It's
right?
Literally dismissive.
It was very dismissive, but now I think he's been able to prove the association between post-infection states and then people developing IBS, right? And so there's he's actually shown that 30% of people who have IBS, that the diarrhea type and
Right.
even the bloating type, have SIBO. And so if we're able to treat the SIBO, then a lot of their symptoms of IBS actually go away.
Yeah.
Yeah.
It sounds really simple, but how do you really diagnose it? It seems so complex whenever the gold standard is you got to go in with a duodenal like aspirate to
Yeah.
kind of actually get the gastric juices.
Yeah.
So is that really realistic or practical?
Yeah, and maybe that's why it's been so hard to diagnose because the gold standard, as you're saying, I mean, how many people can really go in there and do endoscopy and then suction the juices from the small bowel
Yeah.
and bring it back up clean? Because it's going to get contaminated with what we see in the stomach
Yeah.
and the food pipe and the mouth.
Right.
And so that's why it's been really hard to do. And then also, we were just talking about this before we got on the
Yeah.
show. We said SIBO is not just in one part of the small bowel. Sometimes we'll see it in the beginning portion, the middle portion, and sometimes the end. So like you were saying, well, would you have to do a colonoscopy
Yeah.
and get the juices, and then it becomes complicated. And I think these are some of the challenges to making the diagnosis because the tests we currently have are not perfect. Like what tests do you use when you're seeing patients who you suspect SIBO?
Well, we started with one that only include like methane and also hydrogen.
The breath test.
Yeah, so just the breath test because it actually, you kind of blow your test tube in like 20-minute increments for like 3 hours long, right?
That's a home test. You take
home
it
test.
home.
Yeah, you take home. You don't do it out of the office.
Yeah.
You kind of spend your Sunday morning just 3 hours dedicated for this.
Yeah.
And you breathe into these tubes every 20-minute increments. But sometimes there's also a lot of defective collections
Yes.
too. So I know that's also difficult
That's
for some
true.
patients.
That's true. The time it takes to do the test is not easy. And then I think patients have to eat chicken, like a very bland diet for
Yeah,
12
like
hours
potatoes,
before
rice.
doing the test,
Yeah.
right? Y'all, if you've done the test before, let us know what you had to eat. Type it in. We think it's like potatoes and rice and chicken.
Yeah,
That's
it.
all they can
And
eat for
you
12
you can't
hours.
eat- I don't know if you even brush your teeth. Do you brush your teeth? Like
I don't know. I hope you brush your. No, you're not supposed to brush your teeth because of maybe the sugar.
Or the mint.
Or the
I don't know.
mint that affects, yeah, you're right. So it's a hard test to do, but eventually patients do it out of desperation almost, really,
Yeah.
because they really want to get to root cause to what's going on. And that test that you're describing, the one that releases hydrogen and methane and detects that in the breath test, is a good test. So what basically happens with that is that if you've got bad bacteria in your gut, these bad bacteria, when you drink a sugary drink and the bacteria break it down, and when they break it down, Shannon says it's rice, chicken, and broth, and a very bland
We got
diet.
close.
Okay,
We
you got
close.
close, yeah. When the bacteria break down the sugar, the lactulose, it releases hydrogen and methane. And this hydrogen and methane is released into your bloodstream, right? And then the most vascularized organ in the body really are the lungs.
Oh.
So the blood circulates back to the lungs, and that hydrogen and methane is released into the alveoli.
I didn't know that.
And then you breathe it out.
Yeah.
That's how you can detect it on. And so the different quantities and concentrations of hydrogen and methane really is a direct reflection of what is going on inside the gut, the microbiome, how the microbiome is releasing substrates. Fascinating, huh?
Yeah, I didn't know that.
You did
I
not.
didn't know that. She taught me.
We keep learning every day. But what is the new gas that was recently added?
There's actually this new kit called Trio Smart, and some patients who have negative results for methane and hydrogen, they kind of maybe fall in this category with hydrogen sulfur. And so before we didn't have a way to really diagnose it. We kind of did it based on clinical presentation and also because there's so many questions of not knowing if this is a faulty collection or if they fall into this category. So with this new test, it actually kind of helps us bring into light all these patients who may have this sulfur gas in their as part of their SIBO diagnosis, and also would actually change the way that we treat it. So,
Correct. So it's almost like we were missing a complete species of bacteria that are hydrogen sulfur producing with the initial test. And now hopefully we're able to capture that species of bacteria instead of telling a patient, well, your tests were negative, so you don't have SIBO, but they actually have SIBO.
Yeah.
And the test itself is only about 75% sensitive and specific. So imagine we're missing 25% who may be a false negative, but actually have SIBO.
I know some patients are bummed whenever they say, "Oh my gosh, my SIBO is negative." Like,
but we clinically, right? It seems like they have SIBO, which is why sometimes at our practice we'll keep digging and we'll do the stool test, right? We'll do the stool test that's a lot more actually can speciate some of the bacteria for us and guides us in some different ways. But even the stool test, guys, the comprehensive stool test with those specialized labs that we sometimes use, it's not perfect. There's still more that needs to be developed. I went to a conference, an online conference with this gut microbiota group that I was telling you about. This is a wonderful group from Europe that does, and there's some American docs in there too, but they do all the work on gut microbiome, like the latest cutting edge research. And I showed one of them our comprehensive, like I don't want to name the name of the companies, right? But actually I showed them all the comprehensive, and they said, Dr. Asamoah, this is a skittle, and it's like a drop in the ocean. You guys are missing like hundreds and hundreds of pages of RNA sequencing of the bacteria, because they suspect there are trillions of gut microbiome bacteria, trillions of species. And on those tests that we get with the comprehensive GI panels, they said you're not even capturing the majority. So we are so far off from how to really, truly confirm SIBO. Because at this point, we're kind of treating everyone similarly.
Well, I mean, I guess that goes into my next point. Why, like, how do we treat, and what makes it so difficult to treat? You kind of answer some of
that. So we treat with, it depends on the severity. So we grade it mild, moderate, severe. And what we always try and do is identify the root cause. Why does this person have SIBO?
Right.
So what are some of the causes that you know of SIBO, like you've seen in patients where you would search for it?
I think I see a lot of them. Typically, they come with some bloating, right?
Yes.
And a lot of times that's kind of that's it. Like,
the main symptom.
Sometimes there's patients who have burning tongue.
Yeah.
Or they have numbness, tingling. Those are really some odd symptoms. Whenever I see them, I'm like, well, this is not really typical GI. Like, it makes me kind of question.
Yeah.
So what could it be? Do we think it's common causes like inflammatory bowel disease.
Like some of the common causes of what could lead to the SIBO, right?
Right,
I
right.
got you, yeah.
Yeah.
IBD is a common cause, Crohn's disease,
Right.
UC.
Even I kind of see it with some patients with motility disorders like hypothyroidism
Yes.
as one of
Yes.
them.
Yes, Hashimoto's disease, a lot of autoimmune stuff,
Yeah,
because
that's right.
thyroid and IBD, both autoimmune conditions, right? Yeah, yeah, absolutely. Those are some of the common causes. We also see them quite a bit in people who had abdominal surgery.
Right, you mentioned that
So
earlier.
people who have scar tissue, so our patients with endometriosis, who have a lot of internal scarring, we'll see it in our patients with PCOS commonly. Any form of autoimmune disease can also be associated with SIBO. The studies have even shown that it goes beyond just the autoimmune stuff. We see it in brain trauma, right? Like,
Really?
absolutely, we see it in brain trauma. That's a whole different world of central nervous system issues causing SIBO.
Oh, I think that makes sense.
Yes.
You see, everything is connected.
Everything is connected. That's the brain gut connection
Yeah.
right there. So we see it a lot in brain trauma, even like concussions. So there's an interesting article on concussions in athletes and them developing gut issues because of that. It's that connection between the motility
Oh, yeah.
between brain and gut, right?
Right, right.
We see it there. Who else do we see it in? Of course, we mentioned the IBS population. We're kind of seeing an ever-growing population of patients who are predisposed for SIBO, but we know about the medication that we give in GI that can predispose you to SIBO.
Oh, antibiotics.
One, number two, we were talking about PPIs, and we were talking about how PPIs cause low stomach acid.
Right.
And because you have low stomach acid, acid is naturally in the stomach to kill bacteria, like
Yeah.
from your mouth and everything. So whenever you have low stomach acid, it increases your risk of infection, right?
Yeah.
Right? And so all this bacteria can get into your small bowel and populate your small bowel, and that causes
SIBO.
SIBO.
Yeah.
So that's one of the main, that's quite a common cause of SIBO. Thank you guys for joining us. We hope we can connect the two, but that's quite a common cause for SIBO in today's world, other than the risk factors that we discussed. Yeah.
So going back to treatment though, so I know that we usually treat with Xifaxan and sometimes in some cases with methogenic, meaning high methane producing SIBO, we actually have to do two medications with the Xifaxan and neomycin.
Yeah.
Now, are there other alternatives to treating SIBO as well?
There are, and I think that I usually don't start with antibiotics right away.
Okay.
I will try, depending on how severe the SIBO is, whether it's mild, moderate, or severe,
Yeah.
I will treat based on the severity and also try and personalize it in terms of the patient, right? So if it's someone who's already been on a ton of antibiotics and we think antibiotics were indeed the cause of their SIBO, I try to avoid antibiotics. I will use herbal antimicrobials. So we know there are herbal antimicrobials that work, like oregano, wormwood, berberine. So the naturopaths have been doing this for years, and I kind of learned from them in doing the functional medicine training what was the best protocol to use. But the struggle we're having with even regular antibiotics is that if you're not able to really culture the strains that are causing the issue, you're just kind of throwing the same thing at everyone.
Yeah, it's just a big blanket.
It's a big blanket, and sometimes that's why the SIBO treatment fails, right? But I think that in today's medicine, and I think this is really where I want us to go, Donna, in terms of research. I keep pushing her. We got to do research for our patients. But where I want to go in terms of research, or I'm going to bring this down because Donna's petite.
I know.
She's petite, so we want to make sure she's captured, guys. Where we want to go is we want to see if we can find ways to actually continue to provide personalized medicine, but precision medicine. Precision medicine being that we are actually finding the strains that we need to eliminate and repleting with the right species and strains that we need to restore.
Yeah,
You
so
see?
then we can see a lot more results with our patients.
Absolutely,
That's
absolutely.
where we have to go.
Yeah,
Yeah. So we do treat with either antimicrobials, antibiotics if we need to.
Right.
Rifaximin and neomycin is like a blanket one because we know that it works about 90-something% of the time. But these days, if someone's already done that, we won't do that again, right? We'll try and find different species, different strains to do. We want to make sure their bowels are moving well. So making sure they're on the right pro-motility agent is good. We want to make sure that they are digesting well.
Yeah.
So we often will add digestive enzymes.
Right.
And then we have a whole protocol where after we eliminate, we then repopulate the gut, restore the gut. So you have to work with someone who knows what they're doing. And very often in conventional gastroenterology, the way we learned about SIBO was pretty much antibiotics and you're done.
Yeah, that's how I kind of read it when I first came into her practice, but I didn't know what else to do.
Yeah. So nutrition is a huge part of it in trying to make sure that you are not feeding the bacteria with the wrong things and that you are restoring the gut with the right types of foods.
So that's why it's so important to incorporate nutrition into the program, because sometimes we can throw antibiotics at it or antimicrobials, but oftentimes it can come back. And so we really have to look and focus on diet. Is it also things that we're kind of introducing and causing the leaky gut?
Absolutely. Nutrition is extremely important in that treatment as well. Yeah, very, very. So we have a dietitian in our office who helps our patients with the nutrition component. Bianca's really good at, we use different protocols depending on what the patient needs are. It's not a one size fits all. Again, precision medicine and personalization of care. Everyone is different, so it's a little bit different for each person.
And I think it's good to also check in on our patients, especially because sometimes it's trial and error a lot of times, and not knowing what is working, what's not. And so we kind of check in with a lot of our patients oftentimes to see what is their struggles and how do we help them with success, right?
Yes,
so that's
especially with the nutrition, because that's a really hard part, because they have to restrict, but then we also don't want them over restricting, right? So we try and restrict for a certain amount of time, and then we want to bring the foods back in slowly and kind of see what they're sensitive to and what's worked well for them. Guys, thank you for joining us again. You know this internet problem, but I'm so glad to see so many of you back on with us. Please ask questions. We're going to be checking to see if you guys have any questions, and let us know if you can hear us really well. Awesome. That is wonderful. Let's talk a little bit about fungal overgrowth, right?
I don't know much about that.
So fungal overgrowth is, I think, just as important as SIBO, but probably not getting enough attention. And the issue with fungal overgrowth is, imagine if you've got dysbiosis, and wonderful, they can hear. If you've got dysbiosis and there's an imbalance in the ecosystem, why should it affect just bacteria, right? It can affect viruses, bacteria, parasites, because parasites do coexist in our gut, and it can also affect fungus. But some people are going to be more prone to fungal infections, right? And so very often when we treat SIBO and it's not going away and we're not really sure why, maybe your breath test comes back negative this time, right? Because fungus does not impact the breath test, then you have to start really talking about, could this be a fungal overgrowth? And that requires a completely different approach for two reasons. One, we would treat with antifungals and even use the herbal regimens that are more targeted towards fungus. And then the diet is an anti-candida diet. And that is primarily a very low sugar diet, almost no sugar diet. And so that's where we see success. So in our functional gastro program, we will often ask patients about, are you prone to yeast infections on the skin, vaginal yeast infections, toenail infections? Like, how often do you get this? And when you have a patient who says, well, every time I eat sugar, I get some kind of rash, or I get an infection, or I get vaginal yeast infections often, that leads us more towards a diagnosis of there could be SIBO and SIFO, right, mixed together, and we have to address both. If not, it won't heal.
So is it more common in women than it is with men?
I don't think so. I have seen it in both equally the same. It's just that when you're talking about SIFO with women, they can easily describe the vaginal yeast infections, right? But with guys, very often they will describe groin infections with SIBO, or under the skin infection, armpit infections with SIFO, fungal yeast infections, toenail infections, things like that, or just even skin issues with SIFO. So I think it's equally as common.
So it sounded like SIFO is more like how would I say? There's not really a big test for it. So
No, that's
just elimination.
yes, yeah. For SIFO, there isn't a perfect test, but what I have learned, and that is just through doing research, is there is some blood work you can do with regular Quest and LabCorp.
Yeah.
I check for the Candida immune complex. I check for the Candida immunoglobulins, just to see how much your body is responding to it.
Right.
And I have been able to use those tests quite well, because when I put patients on treatment, I will then check it, as the treatment is going along, to see how they're doing. And in some of these comprehensive stool tests that we described, those companies that we said,
they actually picked it up.
they picked it up on a couple of patients. They pick up Candida in stool in significant amount. And that really is a clue that, SIFO is a problem in this scenario. Yeah.
Is it more stubborn to treat SIFO than
Yeah.
SIBO?
Absolutely. I do think so. And because of certain things, again, it goes back to precision medicine. I'm all on this precision medicine thing, right? Because if you're not able to identify the strains, then you put everyone in a big melting pot, right? Right now, we are treating SIFO with nystatin and things like fluconazole. But we also know that the Candida of today, right, the yeast of today, is quite resistant to a lot of those common antifungals.
Wow.
And so in some patients, I wish I had the specific strain and could test for sensitivity, so I could figure out, do I need to treat with voriconazole, itraconazole? Are we looking at other antifungals? Do I need to treat for longer? But for now, I treat primarily. I don't know if I want to share too many of my treatment protocols, Donna. They need to,
you see how excited she got, right?
I don't want to share my treatment protocols because no, you got to come to our practice and we'll tell you.
You got to find out.
You got to find out. You got to find out. But we're thinking of these things, right?
Yeah.
We know it's not the same for everyone. We know that and I think this is the thing about functional medicine. There are many functional medicine providers out there. But I think it's nice to actually get your care from a functional gastroenterologist, because we know the science. We've worked at the microbiology labs. We know that all fungi is not the same. We know that if you get resistance, it really could be because you're treating Candida fruensi instead of Candida albicans, right? Right. So if you go see a registered dietitian, does she really know this? I'm not hating on anybody, but
it's very complex.
It's very complex, and you only know what you know. Right? And so when you see some of the limitations, you realize it's because it's so complex. And so with SIBO and SIFO, I really think it's sort of like a breakthrough in medicine right now with the Human Genome Project, microbiome project, that I think we're going to get there. In 5 years, I think we'll be treating SIBO and SIFO very differently to what we're doing now. I don't think we'll get patients. Some patients are frustrated because they're like, this is my 4th treatment. This is my 5th treatment. It's because we don't really know. And so I think we'll get to a place where we understand exactly what's going on with the microbiome. What is going on with this person's motility. Very precision medicine in terms of customize the treatment plan for every single patient, and not just, and get some good research.
That's the
point. We need some good research to support what we're doing to better care for our patients. But we can't share all our secrets, girlfriend.
Well, it's changing all the time. So.
It is changing all the time. We keep reading these articles and we're like, oh, this is what we should be doing now. And so you also want a provider who is keeping up with the literature, who is following the trends and seeing the changes and things that are new coming into the literature to better help our patients.
Absolutely.
Yeah.
And even having providers that take the time to listen to their patients, because sometimes you often miss that. So that's the whole point of us being able to give the quality care that our patient deserves.
Yes. The time you spend to really get to understanding the root cause and how somebody got into this diagnosis of SIBO or SIFO is a long time. We've talked about some functional medicine patients that were in just our regular, GI programs before, where, you have 20 or 30 minutes with a patient Hello. Hi. You have 20 or 30 minutes with a patient. It's not enough time.
Yeah, it's not.
But when you spend that 90 minutes and we go all the way back to root cause, where were you born? What were the toxins you were exposed to? Were you breastfed as a child?
Right.
What foods were introduced? I discovered some things about my patients that I had no clue about. And then it was like a light bulb. I'm like, no wonder. That connects everything. No wonder you have SIBO. It started here.
Yeah.
Remember that patient I told you who was eating sushi all the time?
Yeah, and you wouldn't
You wouldn't know in a regular visit that that was the case. Hey, Jan. Oh, Jan, how are you? Good to see you on. So spending that time with patients really helps you understand this diagnosis. And we're here talking about SIBO and SIFO like it's an everyday bread and butter thing, right? But it's a diagnosis, it's a differential that's emerging.
Yeah.
It's one that we're learning a lot about in terms of how to diagnose and how to treat. And so again, SIBO is small intestinal bacterial overgrowth. We tend to look for this diagnosis in people who have gone through all sorts of conventional testing. Right? They've done EGD, colonoscopy, pill cams, endoscopic ultrasounds, all sorts of testing. And their doctor says, we don't know what's going on. Like there's nothing, your tests are normal.
Yeah, it's IBS.
It's IBS, right? they say it's IBS, right? You're constipated or whatever. And then, we see them and then they start telling us about their story. We may hear about abdominal bloating.
Yeah.
Changes in their bowel habits. I used to be regular before, but now it's diarrhea or constipation or both.
Right.
I feel tired all the time. I've noticed changes in my skin. I have brain fog. That's a common one with SIBO, right? Brain fog. Certain foods make me worse. And so those are the things we won't repeat your colonoscopy at that point. We know we have to dig digger within the microbiome to kind of figure out what's going on. Yeah. So it's a very interesting diagnosis. Hey. Hi, Justine. How are you?
Wow, we have a lot of people.
I know, but it's our last night. I guess
know.
this is the finale. This is the closing of all of this, So guys, we've probably gone on for way too long. There's so much more we could share about SIBO and SIFO. We are blessed to be in the field of gastroenterology, which is an evolving field. We are learning every day about these diagnoses. You have to ask your GI doctor or your primary care doctor if you suspect you have one of those diagnoses. Can I get a breath test? Can you at least do a breath? The breath test is available everywhere. TrioSmart, I think, partly covered by insurance, right?
Yeah.
And even with the Aerodiagnosis, we love that group. Gary is a great a scientist who works with us for a breath test, but I think his is under $200. And so something that's important is before you start treatment, you want to test. And then shortly after treatment, we test as well because we want to see what progress is happening. We don't want to assume because we don't want you to bounce back.
Yeah.
We don't want recurrent SIBOs at our practice. We're trying to sort of nip it in the bud.
That's right.
Right. We're trying to nip it in the bud. So it's an evolving practice. We've now sort of made this part of our functional gastroenterology practice because we believe that is where we get the best outcomes. We have time to discuss histories with patients. We have time to discuss nutrition with patients, and that takes a lot of time.
Important.
It's important. It's a big part of the process. Yeah. So Donna, thanks for coming tonight.
Cheers.
Guys, cheers to our last gut over it. We are over it. But we are very excited to start our Facebook group coming next week. Hopefully, I hope we can get it together for next week, but we have great things lined up. I hope to get Donna on there more often. Bianca, who's our dietitian, will definitely be on there often. We'll be doing once a week, at least, videos.
Okay.
I'm trying to get Dr. Jerry Mullen, who is who is one of my mentors at Hopkins and a big functional medicine gastroenterologist, to come on and do some podcasts with us. I've met some wonderful people through this gut over it. People from,
Really?
naturopaths from California that have reached out, and I hope we can all get them onto the Natural Gut Relief Facebook group. So, keep us in mind. Next week, guys, we'll be opening it up for everyone to join. And we thank you guys for joining us.
Yeah,
and Donna,
thank you guys.
Thank you for being an amazing physician assistant. She didn't want alcohol. She was like, Dr. V, you got to do
It's
water.
too late.
Keep it clean. Keep it clean. So I'm being good. Have a wonderful evening,
Bye.
guys.
Good night, guys.
This was a lot of fun. Thank you so much for joining us. Please leave a message on Facebook. Can I be a guest? Absolutely. We want patients on there. Absolutely. To tell us about their stories. Absolutely. We definitely want patients on there to share their journeys. And this is always encouraging to other patients, right?
Yeah.
When they hear someone going through a really, some people are just suffering with this.
I know. They think they're going through this alone.
Alone, they are not able to get help from providers. And I think a patient, someone who went through the same experience, who got out of it and is doing great,
Yeah.
really the best way to go. I think that's the best testimony.
That's the next step for us.
That is the next step. That is the next step, getting our patients on and being giving their own testimony. So you guys have a wonderful Sunday. It is 9:41. We got to get off, and we will
Good
see
night,
you this
guys.
week. Good night. Leave a review on Google for us. What is UC? Ulcerative colitis. We talked about it in one of the Gut Over It. So we'll let you guys go back and watch that. Have a wonderful evening. Bye, guys.
Bye.